So, welcome to this webinar. As Andrew said, we did this yesterday, and I had a few questions, so I'll have a few extra things to maybe talk about today, based on some of the questions that I heard yesterday. The reason why I'm probably presenting this webinar is twofold. I am currently working as a family physician in the residency training program, so we do a lot of teaching around documentation and making sure people have up-to-date records and following the guidelines. The second reason is another hat that I wear, and that's I'm an assessor for the PEP program, or the Physician Enhancement Program. So if you've had the benefit of a PEP assessment, you know exactly what I'm talking about. And if you had not that privilege yet, I'll tell you briefly, quickly, what that program is about. So it is a peer program where physicians like me would come to your practice and do an assessment of various aspects, including your practice management, your practice setup, but then also a chart audit. We select a few conditions and we ask you as a physician to pull charts for us or identify charts. And then we have a criteria that we use to go through those charts with those conditions, and then we'll give you feedback afterwards. And I've been doing this for a decade or so, and we've asked some of the other assessors to give us some of the themes that comes up during these assessments, and especially around charting and documentation. So hence, I will be using a lot of those examples and refer to the PEP program frequently during my talk, as it applies to what we're talking about. So to get going, I'll briefly just tell you what I was planning on talking about. So first of all, before we can get going on any talk about documentation, there is probably a need to look at some of the medical legal aspects around it. So what does the law say that we have to do? Then we'll talk about the different components that make part of a good clinical record or a patient record. And then lastly, if I haven't done it at that point yet, I will identify common errors that occur during medical record keeping. Usually, as I talk about these different things, I might highlight some of the errors that we see at the PEP program or even in the residency program. So with that in mind, I'll start with the legal aspects. And just to orientate you a little bit, you all know that we as physicians in the province work under the Medical Act from 1981. The Medical Act itself has nothing specific to tell us about medical records because the Medical Act delegates all of its powers to the College of Physicians and Surgeons. And so the College of Physician Surgeons have two sets of bylaws. One is administrative bylaws, and that's to do with your incorporation and stuff like that. And then there's a set of regulatory bylaws. And specifically, bylaw 23.1 talks about the medical record. And so I'll mention a few things from that bylaw just to get us going on this topic. And so the minimum requirement, and you'll look at some of these things and you'll say, oh, it's obvious. And that's okay. But sometimes the obvious is sometimes the things that we overlook. But the minimum requirements for any patient record states that we have to have the demographic information of the patient. So obviously the name, address, date of birth, and the health number. For any interaction with the patient, we need to date the interaction. And if you're using an EMR, it also timestamps many of the things that you do. If you are doing a consultation, the requirement is that you have a comprehensive note, and the recommendation is using a format such as the SOAP note, and we'll talk more about that a little later. And then the one thing that we see often missed in the record is the disposition of a patient after an interaction. And I'll talk more about it later on, but basically you need to document what the patient is to do next or what instructions were given to a patient at the end of an interaction. Other things that they require of us is to include all reports respecting a patient. So if you ever receive a report from a surgeon or a pathology report or a lab report, it has to be included into the patient's chart and should be accessible at any time. You'll maybe smile at the next one. Your record has to be in English. But over my years as a PEP assessor, I came across 2 clinics already where the records were kept in a different language that's not understandable by people, and the college will not accept that. So your records must be in English. Your records must be timely, and this is a tough one because the bylaw doesn't state exactly what they mean by timely. And so I'll tell you what we teach our residents here in our clinic, and that's that you should complete your interaction note within 24 hours of seeing a patient. And there's lots of reasons for that. I mean, first of all, I don't remember 2 days later what I did for a specific patient. And you know, if you had a busy clinic, even at the end of the day, you kind of, was that this patient or was it that patient that said this or that? So it is important to try and complete them as soon as you can, just purely for the sake of your own memory. The other reason why it should be timely is for continuity of care. If someone else needs to take care of a patient after your interaction, say, for instance, that evening on call or the next morning, it should be clear to them what happened during the consultation today, especially your management plan of what you decide the patient needs to do. So for those 2 reasons, it's important to complete your records in a timely way, and we suggest 24 hours. And then the bylaw states that your record can be electronic, and that will be a little bit of a focus of our talk today, is just to talk about the EMR part of it. But if you at any point have questions just about paper charts, by all means, let me know. And I did check with Andrew yesterday, and currently in Saskatchewan, the uptake for doctors transitioning onto an EMR or into an EMR is about 82, 83%. So we're doing okay, but I was hoping that by now we'll be high in the 90s. But well, it's still a work in progress. When the bylaw talks about electronic records, some of the things are very intuitive or obvious. It must have a visual display, so a monitor or somewhere. And what we do in our clinic is have the monitor in such a way that the patient can see it as well. So often I would point to something in their chart, show them stuff, and so it is important that the patient can see what we document and what we have on their chart. There must be an easy way to access the record, and that means you need to have a computer set up or a system set up in your clinic. But if you are doing a lot of call from home or for somewhere else, then you need to have some way of accessing your records remotely. And most of the EMRs can do that. You have to be able to print the record. And that is because quite often we get requests for copies from lawyers or insurance companies, or even the patient themselves. So make sure you're able to print. This is maybe not that important because most EMRs will take care of it anyway, but your records must be in chronological order. This is more a big deal when you're dealing with paper charts. Most of the EMRs will have the latest document at the beginning of your search. All EMRs must have an audit trail, and the 2 current vendors that we use in Saskatchewan do have an audit trail. But that means that anytime you make a change in your record, so if tomorrow you remembered something about the patient interaction and you add that to the record, it has to date stamp that and will be able to identify that you altered the record at a later stage. So that must be done. And you'll be interested to see that in Saskatchewan, the bylaw states that we only supposed to keep records for 6 years after the last entry. And you'll immediately think, well, I thought it was 10 years. And I'll come back to that in a second. They say 6 years after the last entry. That doesn't mean last consultation. So if you received a surgical report on the patient a year later or 6 months later, that would be the date of the last entry, and you have to keep your records for 6 years after that. And in the case of children, it has to be 2 years after the age of majority, and in Saskatchewan, that is defined as 18. So you have to keep it at least 2 years after the age of 18, or whichever comes later. So if it's the 6-year period or 2 years after majority. The 10 years thing, I had to look into that a little bit because I was also under the impression it has to be kept for 10 years. And that is what the CMPA recommends for keeping records. And many of the other provinces in their bylaws have adopted the 10-year rule. In Saskatchewan, as I said, it's 6 years, but I would probably encourage people to maybe keep the 10-year thing in your mind and keep records for 10 years. Other legal aspects that I'll just briefly mention, and that's when you decide to retire or leave your practice, there are rules around what you need to do with your records. So you can either transfer to another doctor in the same practice or another practice. You can transfer your records to a Department of Health facility, and whatever you decide to do, there has to be secure, safe storage of the records and confidential. You might remember a few years ago there was this incident where a bunch of records were found on a landfill, and so that will not be accepted. You have to make sure it's confidential and secure. And if you do decide to get rid of it after 10 years or whatever, it needs to be shredded by a company that can guarantee confidentiality. If you are working at a SHA facility, so a hospital or a long-term care nursing home, you also have to comply with the rules that that facility has for completing records. And then, although it's not the topic of this talk, I do remind you to also think about the HIPAA requirements for records and confidentiality and who has access to records. So that was sort of the legal requirements, but if we just look at best practices, there are a few components of a record that we think is very important that must be available. And the very first one is a cumulative patient profile. And the vendors have different names for it, but I think it all comes down to some kind of profile for the patient. And this profile needs to include the medical history, such as diabetes or hypertension, as well as past procedures, surgeries, colonoscopies, that sort of thing. There should be a section for allergies, family history, lifestyle, smoking, alcohol, drug use, social aspects such as relationships, employment, children, and then immunizations. I'll maybe just briefly highlight a few of these because in our experience going for PEP assessments, this is one aspect that's not consistently done properly. You often will come to a clinic and there's just consultation notes and no profile. There are many reasons why it's important. I'll come back to some of them later on, but for instance, a family history is one that we hardly ever see updated. And this is helpful when you start doing risk assessments like the Framingham. So it is important to have a patient profile. And I'll come back to some of the goods and bads about that. Obviously, another component of the record is the medication list. And the EMRs are very good at keeping an updated medication list as you prescribe things. There are a few mistakes that can sometimes pop up in this area, and I'll come back to that later on. But this usually is not an issue. The medication lists are usually up to date. There should be a section for consultation notes, and those would be your own notes from the consultation itself, your own procedure notes or procedure notes from other physicians that you consulted. Any telephone calls, and yesterday there was a bit of discussion around this aspect, and this includes phone calls with the patient, but also phone calls with an allied health care provider. So if you're talking to a pharmacist or a nurse at a nursing home or a physiotherapist about a patient, all those calls needs to be documented as though it was a consultation. And different vendors have different places for documenting these, but it should be easy to find a documentation regarding a phone call. The other aspect about that is now in our pandemic era, and hopefully moving forward, we do have billing codes for phone calls with patients. And so for sure, it needs to be documented so that there's a trail of what happened exactly during the phone call. Another aspect that's part of your consultation notes are flow sheets. So most of us know the QIP program in Saskatchewan. And from that program, the majority of physicians do use the diabetic flow sheets, for example. But just a reminder that there are other conditions that have flow sheets as well. So I'm thinking of COPD or cardiac disease, those sort of things. There are quite a number of flow sheets available. And there's definitely advantages of using these flow sheets. It helps you to remind or to remember things to do, but it also helps to make sure that there's a continuity of care when it comes to certain chronic diseases. Another component is referral letters. So that's referral letters from your end, so letters that you send to someone else, but also reports and referral letters that you receive from other physicians. It needs to be easily achieved or obtained. Obviously, lab, pathology, and imaging reports. So if you receive an X-ray report, there should be a place for that to be filed. And then other forms that you often will have when you deal with a patient. So those are insurance forms, SGI, workman's comp, any physio reports or SLP reports, and then any reports related to the employer, either disability forms or medical certificates for illness. All those things should be filed somewhere in the medical chart. The three that I'm probably going to highlight a little more in the next few slides are the SOAP notes, the procedure notes, and the referral letters, because these are areas that, as a PEP assessor, I often see deficiencies. Yeah, maybe I'll talk about that soon. So the first thing I want to talk about is the SOAP note. And there's no rule that says that you have to use a SOAP note specifically, but most people know this format, and this is the format that's taught in medical school. And there's a lot of evidence behind it, and it helps you document all the things that you need. And so I do see people attempt to use SOAP notes quite a lot, but sometimes I see that people don't often understand the different components of a SOAP note, or maybe put things under the wrong heading, which is not necessarily that bad, but it helps to have things organized a little better. So the S stands for subjective. So that's everything that the patient is basically telling you. And so it could be they're presenting complaints of why they came in for the visit, the whole story about the reason for their visit, any other relevant information that they tell you. So any issues going on at home or at work or whatever. A relevant review of systems. So if a patient comes in with a complaint of, say, cough, then we would expect that you do at least a review of the respiratory system or any other system that you think might be appropriate for their presenting complaint. And then a reminder that it's good to document your patient-centered questions or answers that you get from the patient. And most people know the acronym FIVE. So people don't often document these things in their notes, but it's maybe important to document what the patient's idea was about their illness or what their expectations were of the visit. So I do encourage you to remember to document your FIVE. Objective is basically all the things that you gather from the visit, usually via physical exam and other ways. So for the physical exam, it's obvious you're going to document your vital signs from the patient, any positive findings during your exam, but also remember to document your pertinent negative findings. And so those are things such as a patient with a right hypochondriac pain, that sounds wrong, right upper pain. You want to document a negative Murphy sign, for instance, if it's not present. If you're dealing with someone with mental health, it is important to document whether a patient had suicidal ideation or not, or homicidal ideation or not. And just if I forget later on to talk about this, this is one area that we often see people not documenting things properly. So every patient that you're seeing for follow-up with depression or any mental health issue, it is recommended and expected to document your questioning about suicidal and homicidal ideation at every visit. Other objective things that you might document here is your lab or imaging findings. So if a patient went for her A1C and you want to document the trend or something, this is a place to say something about their A1C going up or staying stable. And then if you use any questionnaires, which we do recommend, then this is a place to document the information you gathered from it. So again, if you use the PHQ-9 form for monitoring patients with depression, then it would be good to put something about that in the objective part of your SOAP note. The assessment, most people think of it just as the diagnosis, but it's essentially your differential diagnosis. So it's kind of your thought process of what's going on, or a working diagnosis at this point. It's also a place where you can put your assessment of the progress of the diagnosis or the potential concerns around the diagnosis. So you could say, for instance, hypertension follow-up, poorly controlled blood pressure, or hypertension and diabetes not well controlled, or something like that. So it's more than just your diagnosis. It's a bit of your assessment of the whole process and the whole interaction. And then the plan, obviously it includes your prescription or medications that you prescribe to a patient. And I'll talk a little later on about the EMR and how you don't have to retype everything again in your plan that you're prescribing. But this is maybe a place to say renew medications for 3 months or something like that, or increase dose of metformin, that sort of thing. Also, remember your non-pharmacological treatment. So if you advise the patient to take lots of fluid and bed rest for their influenza, then this is a place to document it. Any further investigations that you're planning or suggesting to the patient. So if you think a patient should go for a chest x-ray, then this is a place to document that. If you're referring a patient, again, all these things are documented somewhere in the EMR, so you don't need to rewrite everything, but maybe just referral for cardiac consult regarding CHF or whatever. Education, like I said before, including lifestyle. So if you decided to tell a patient to quit smoking, you need to document that. Or if you talk about an exercise program, weight-bearing exercise program, to put that here. Also, if you educate a patient about red flags or things to watch out for. So you might have dealt with a back pain issue and you excluded a disc herniation, but you do tell the patient that if you ever get symptoms of bowel or bladder control loss, then remember to give us a call. Those sort of things are important to document in your note. And then, as we said earlier on, your disposition of the patient or your follow-up arrangements or whatever you tell the patient at the end. So if you said to the patient, return to the clinic, if your symptoms are not improving, you need to document that. And on that note, that alone is not good enough to document. You need to give a bit of a time frame that you advise the patient. So if you just say for instance, a patient with a sore throat, return to clinic if not improving, theoretically that's not enough. You need to give a time frame such as return if symptoms are not improving in 2 to 3 days, for instance. So those are the things you want to document there. Procedures. So many of us do procedures, and this is a way that the records should be documented. So obviously the demographics of the patient and the date of the procedure, and sometimes even the time of the procedure. It is important to name the procedure. Often I read a report and I kind of figure out what was done, but there's no mentioning of the name of the procedure anywhere. So remember to put that on there. It's recommended to name the surgeon, the assistant, the anesthesiologist, or whoever else was in the room. In our clinic, we deal with a lot of residents and students, so I even put their names. When I do a vasectomy, I put everyone's name in there, even if it's a second-year medical student just shadowing, I put their name in there. I was reminded yesterday that we do get consent from patients, and so it's important to document that consent was obtained and probably scan a copy of the consent document into the chart. And then detailed outline of the procedure itself. So any medication that was administered, so if you did a procedural sedation, you want to state what you gave the patient. The position of the patient, were they supine, laying on their stomach, sitting upright, any intraoperative findings, obviously, and then any prosthesis or drains left behind on purpose. So if you're leaving the patient with a with a drain or a colostomy, then that's important to document, or a hip prosthesis, so that people know what's left behind. Any complications during the procedure, so estimated blood loss or any other complications, and then at the end, the instrument and sponge count. And then right at the end, to say something about the status of the patient. Most operating room reports will say something like patient transferred to recovery room in good condition, but something to that extent might be good to state at the end. So there are a few things to remember when you document a procedure. And if you are someone who likes templates, this might be a good template to maybe create for your procedures. The other component that we often see a lot of deficiencies are referral letters. And so the requirements of a good referral letter states that you need to state the reason for the referral. You also need to state a indication of the urgency, so that the person receiving the referral at the other end can make a decision of how soon they need to see the patient. And then there must be relevant medical information of the patient in the referral letter. And this is where it's handy when you have a good updated cumulative patient profile. It's easy to just say in your letter, see attached profile, and then print a copy of the profile and attach it to the referral letter. So again, my little plug for keeping an updated profile helps you when you start dealing with these things. So we often see a lot of problems with referral letters when we go and visit physicians in their clinic. And I think I will talk about it later on again, but if I forget, one of the ones that really always gets me smiling is the one that says, please do colonoscopy. And that's it. That's all that's in the referral letter. And you can imagine that if you're the person receiving that on the other end, you have no idea why, how soon, how urgent, or anything like that, and nothing about the patient. So I don't think that reflects very well on the physician sending a referral. So if you don't know what that is, that's a cookie cutter. And I do want to talk a little bit about templates. Templates are really good, and the EMR especially is very good at it. Back in the days when we had paper charts, we all created our own paper templates that we just fold in. But now we can do that electronically on our EMR. So it's good because it does save you a lot of time. If you're doing something on a regular basis the same way, there's no need to retype the note every time. So in my case, I do lots of vasectomies. I have a template for my procedure note, and I just use that when I do my reporting. The other thing that's good about templates is that it also reminds you of things that you need to do and also things that you need to document. So another format of a template is the chronic disease flow sheets that we use for diabetes, for instance. It helps you to remember to do certain things that you might not otherwise remember. And the one that we all forget is that foot exam that we do in our patients with diabetes. So a template like that will help you remember to do certain things, and then also help you document whether it was done or not. So templates generally are good. So the last part of my talk, I do want to briefly talk about some of the common errors, and I've alluded to some of them so far already, but I'll go over some of them again. So the big one that really is a big deal is the cumulative patient profile. I think it's very difficult to see patients if you don't have a summary of them somewhere. It means that you don't really know your patient well, and you might think you're going to remember everything from a patient, but I can tell you that I've had patients for 10 years, and actually just this morning I read a report on a patient and I forgot that she was a retired nurse. So it helps to have those things in the patient profile to remind you of certain things about your patient, or certain conditions, or even surgeries or procedures that they've had. It also helps another doctor who doesn't know your patient when they need to take over care or step in during a mat leave or a locum situation, or even a walk-in clinic. It helps if there's a patient profile where you can quickly have a glimpse at and get a picture of the patient that you're about to see. If you don't have a good up-to-date patient profile, it's very difficult to do risk assessments. And so if you suddenly think, oh, it would be nice to do a Framingham risk assessment on this patient, before I decide to prescribe a statin, it would be very helpful if you had a family history documented and all the other things that you need. So hence my plea to maybe keep your profile up to date. It also saves time when you're doing a pre-op or a referral letter. It's easy just to say in your letter, "See attached," and then print out a summary of the patient profile. Another aspect of the cumulative patient profile is the allergy tab. And if you don't have that updated, you could potentially prescribe a medication that the patient is allergic to, and the EMR will not alert you to it because you haven't updated the profile. So there's also safety aspects for why it is important to update your profile. The other area that we often see problems in the EMRs are the medication list. So like I say, mostly now we do see a medication list because that's the way the EMR prescribes medications. But if you don't have all the medications, even the external ones that someone else prescribes, you won't be able to get interaction alerts if you're prescribing a new medication. So if someone is on a sotalol prescription and you decide to prescribe something that will also prolong the QT interval, then you wouldn't know that if you haven't updated your medication list. It also helps to save on prescription errors or prevent prescription errors. The other thing that we see quite often, and it depends on whether you use a Curo or MedAccess, is that whole aspect of active or inactive and chronic medication, so continuous versus short-term medications. And I see a lot of issues where, especially in the Curo, a lot of short-term medications are still being kept under the active list. And so someone got amoxil last year for a throat infection, but it's still showing in their active list. And the problem with that is if you send a referral letter to a specialist and you copy attach a copy of their profile, then all those inactive or active medications show up, which gives a false impression of what the patient is actually taking. And so here, if you're using MedAccess, the screen should look familiar to you. So just to orientate you quickly, this is the medication tab. And on the left-hand side, you usually see continuous or short-term. You have the drug there with the strength of it and the dosage and so on and so on. So there's an error on this prescription if you look at it. And I wonder if anyone wants to put in the chat, because I can now see the chat, what they think the error is, or even if you're brave enough to unmute yourself and tell me what you think the error on this prescription is.
Could it be that the amoxicillin should be short-term?
Exactly. So if you look at that continuous, that amoxil was prescribed for a week course at some point, and it wasn't changed to short-term because the default for most of the EMRs is continuous, or the other way around. It doesn't matter, but the provider didn't change it to what it should be. So that continuous amoxil is going to show up forever on any medication list that goes with a referral note to someone else. Other common errors, the SOAP notes, and the real big error here is it's not complete. It's very short, very succinct, and does not have all the information. And we know the mantra, if it was not documented, it was not done. And the College of Physician Surgeons feel very strongly about that. And so I often hear, yeah, but I always, if someone is a smoker, I always talk about smoking cessation. Well, if you didn't document it, the college is going to say you didn't do it, no matter if you always do it. So no one knows what was really done during a visit if you don't document it. And so it means you need to document a few things during a visit, and using a SOAP note properly will help you do that. The other thing is to not document progression of disease or even document it accurately. So often I would see asthma follow-up, prescription, Ventolin, and a signature. So I have no idea whether this patient is doing well, if his asthma is improving or deteriorating, or what the case is. So somehow there needs to be some documentation of the acuity of it. On the other hand, sometimes I do see people document things unnecessary, especially in the EMR environment. And a good example is in your SOAP note, the plan, I often see people type out amoxicillin 500 milligrams TID for 7 days. And then they use the EMR to generate the prescription and even fax it to the pharmacy. So most of the EMRs will document that generation of the prescription somewhere in the note. There's no need for you to also type it in again. That's just duplication and wasting of your time. So to think about stuff like, even if you ordered an X-ray, that is documented somewhere in there. You don't have to state again in detail that you ordered a abdominal ultrasound for this or that reason. It is documented or at least noted somewhere in your EMR. So think about things that you're also duplicating that you don't need to. So here's my favorite documentation. So imagine this is a paper chart, but it could easily be just an EMR one as well. So often I see this in the chart. Hypertension follow-up. I might or might not see a blood pressure reading in there. And then even in the EMR, the whole prescription type out. Signature there if it's a paper chart, and then someone scribbled 5B over there, probably the billing clerk at some point. So I think you will agree with me that that note is not very helpful to anyone else seeing this patient in follow-up. I have no idea whether this blood pressure was taken sitting, standing, just after they had coffee, whether this is an improvement because last time their blood pressure was 160 over 110. So nothing like that. And I don't know if there's any extra conversation that happened about lifestyle management. Maybe this guy needs exercise and it was discussed, but it wasn't documented. So I think you will agree that this is unacceptable. And if ever you get audited by the medical MCIB, then you would be found guilty of incomplete records, and you will not be able to bill for this, and you'll be asked to pay that money back. So make sure that you document thoroughly. Another one typically is there's depression and just a prescription. And to me, that would not be the appropriate medication to prescribe, but maybe there was a good reason for that, but I wouldn't know that from this documentation. I have no idea if there was a question or discussion about suicide ideation. And as I said before, it's one of those sticky points where we do think you need to document that at every visit when you deal with someone with depression. And again, a 5B, if you bill a 5B for this, you would be asked to pay that money back during an audit because this note does not meet the criteria for billing purposes. Here's my other favorite. So diabetic follow-up, doing well. So a little more information here, and maybe A1C documented there, blood pressure, renew meds, so I don't have to worry about that. It's documented somewhere else. And then the codes for the QIP, 64B and 65B. So anyone, can you tell me what is wrong with this prescription or just this whole note? Okay, so no one is venturing. Oh, Jill, go ahead.
Well, now, don't you have to have done the CDM QIP worksheet to bill one of those?
Exactly. So you're not allowed to bill a 64B and a 65B if you did not use the flow sheet for that condition. And so that was not used here, so you're not able to use those codes. And also the note, even though slightly better, does not have everything that they need on it. So that just brings me to the point of billing errors, and this is not a billing talk, but I will point out that every billing code has requirements for documentation. And a good example is the 3B, or the complete physical or periodic health exam. So there are a few things that the billing schedule require you to document and cover during a PHE before you're allowed to bill for it. So if you did not update the cumulative patient profile, for instance, you cannot bill a 3B. And so are there criteria for every other billing code out there. And so it might be a good exercise at some point for yourself, for many reasons, but for sure for this part, to maybe quickly page through this fee schedule again and just see what the criteria are for the codes that you build quite frequently, so that you know that you're at least covering those minimum requirements for those billing codes. The other error that we often see is template errors, and we call it template abuse or template misuse. It's quite common. And the reason it happens is that we think we do the same thing every time and it's cookie cutter, but sometimes things are different in a specific patient. And so we just copy and paste or whatever process we use to put the template in there, but we don't actually read through it quickly to make sure that it's relevant to the patient that we just saw. So it is important to edit the template every time you use it. Don't just copy and paste it. And I'll come back with an example of that. The other common error is that any forms that are used are not updated into the patient profile. And so it definitely wastes your own time. If you do a social services form every year, if you scan the copy in, next year when you have to do the same, it's easy to just look at what you did last year. And if nothing changed, you can just rewrite the same thing. So it definitely saves you time. So this was a report that I actually received from a specialist not so long ago. And so patient was seen for a headache follow-up. That sounds good. And there was a bit of information about the subjective findings. And then it comes to the physical exam. And it states that the mental status was normal, visual fields were full, and eye movements normal. The optic discs were normal, visual acuity was fine, da 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 da. Do you think there's anything wrong with this note? And I don't expect you to answer because you might not know this patient, but I do know this patient. So this patient only has one eye. And so when I read this report, I'm like, oh yeah, this guy just copy and pasted his typical neurological physical exam, and he didn't read through it to make sure that that is actually what happened during the visit. And then I'm starting to wonder, did he actually examine the patient? So I don't know. And the rule says if it's not documented, it's not done, or if it's documented one way, then it was done that way. And so I don't know where to go with this note. So my plea here is to read your templates. Many of us have received abdominal exams from a specialist on a female patient, and it comments on the prostate during rectal exam, or a female patient who had a hysterectomy, but the note says that her uterus was anteverted or in normal position or normal size. So just a reminder that if you are using templates, to actually read them before you send them out, and be careful not to fall into the trap of cookie cutter things. So I talked a lot, and I do hope that you have questions, because that's usually where the richness of this conversation goes. So if you have any questions, I am able to see the chat function as well. So if you want to put a question there, or you can just unmute yourself and we can answer your questions.
Didn't see anything come up in the chat, but anybody has questions they'd like to ask, please feel free.
There was a question yesterday about if we document things differently when we're doing virtual visits with a video call and a phone call. And so the one thing that's a little different is that I think it's important to document the security or the confidentiality of the call. So in our EMR, we have a template, for a few things that we check before we start the phone or video call. So we check, make sure the patient is alone, that there's no one else in the room, that they're aware of the fact that you're phoning them or talking to them. And sometimes what I do is if I use a video call, I might actually take my camera and just show them the room, that there's no one else in the room. Or if I have a student with me, I will tell them that. And so it's important to document a few of those checks that you do at the start of a call. And then we also have a check at the end of the visit note to say were there any breaches of confidentiality. And so we make a note about that. So that's just the one thing that's maybe extra with your phone and visit calls during the pandemic.
I had a quick question about prescription renewals that come from the pharmacy by fax. Just wondering, like, along best practices, would you recommend that they, just send that renewal form back, or that they document it in, like, sending a prescription? How do you, like, how are most people doing that process?
Yeah, I think I understand your question. So the way we do it is if I get a fax renewal for, say, metformin on a patient, I don't actually write on that form and fax it back. I go to the patient's chart and generate a new prescription or a renewal on the EMR, and then fax that over to the pharmacy, because then I know that my records are up to date as well. Otherwise, I feel if you're going to print out the form and just write on there, yes, renew 3 months and fax it back, at some point you still need to update your records, and then that's just duplication. So I just look at the fax request, and then I go to the patient's prescription list, and then I renew it from there and fax it from there. Does that answer your question?
Yeah, perfect. That's what that kind of confirms what we were thinking. And then to follow your workflow to the next step, how do you remember to do the bill for it?
So I have to tell you that we have a really, really, really awesome physician in our clinic that make templates for most of these things. So when I get a fax refill, the receptionist or whoever scans it in attaches it to the right template for us, and in that template is a reminder for the billing. And so I renew the prescription, and then I just type in the diagnosis and I click on a certain button, and at the same time it will close that visit for me and generate a bill for it. And so I think it's worthwhile to find a champion in your own practice or in your community on the EMR system that you use, and maybe the SMA can help with this as well, to help you generate those templates that make life so much easier. Because really, if I know exactly why you're asking that question, because if it wasn't for that template, I probably would forget to bill half of those visits or those fax refills.
Thank you. That's helpful. You must be a MedAccess user then.
I am.
Yeah, I don't think Akiro has the same type of workflow, but yeah, thank you.
I wonder if we could get that colleague of yours to do a webinar on templates.
I try to tell you to ask him, but I think he says no quite frequently because he has a lot on his plate. But I wish I can clone him. If I ever have to leave this clinic and go somewhere else, I will hire him for a week or two to set up all my templates for me. It's kind of his passion to do that. But he's also on MedAccess. I'm not sure if he knows much about Akira, but if you have a MedAccess issue, I think for enough money he might be able to help you. I'm just joking. I don't know.
Okay. Does anyone else have any more questions before we wrap up here? If not, I'd just want to thank Dr. Miller for doing this. I think this was very informative. And the recording, again, will be available on the EMR website. So thank you very much. And thanks, everybody, for attending. And we will see you later.
Thank you very much. Have a great day.
Thank you.